Hello. In this video lecture, we're going to be discussing patient record content per chapter 4 in the textbook. Okay, and again, this is getting into the content of the patient record. So let's start with the purpose of the patient record. A patient record serves as the business record for patient encounter. It contains documentation of all the patient's healthcare services, and it's a repository of information that shows both demographic information and clinical information. This is the same whether it's in a paper format or in an electronic health record. So we need to be very clear about who owns the patient record and what exactly we're talking about when we're talking about ownership. The patient controls the release of the information subject to state, federal, and local laws. And the hospital is the owner of the medium. So you can't show up at a hospital that uses paper records and say, I want to go home with my paper chart. It doesn't work that way. Likewise, with a hospital outpatient record, you can get copies, you can get duplicates, but you can't get the actual one and only record. And this applies to the patient, the physician office records, and other healthcare settings as well. And again, the goals are the same, whether it's paper or electronic, right? Paper hospital records typically cover just the patient's hospital stay, right? As more and more things go and really fall outside the scope of the hospital, right? In terms of admitted inpatients, you have what we call hospital outpatient. These are things like labs, imaging, and what have you, right? And again, as we keep having more and more healthcare services that get provided on an outpatient primary care, this is another area that we're focusing on and under increasingly more scrutiny. Used to be just the hospital records were closely scrutinized by payers. Now we're seeing that same kind of attention to detail fall over into the outpatient side. Regardless of the type of care provided, a healthcare facility's patient records have a lot of the same types of things. And if you've been a patient, these are familiar. These are the consent forms, the payer authorization forms, patient identification, all those different types of things. We can have other different formats depending on the healthcare setting, and these will vary a little bit. We wouldn't expect to see behavioral health have the same type of record content as a hospital or home health or hospice because of the differing nature of their care. When we use the term demographic information, we're talking about patient information, their name, their patient ID number, their date of birth, their place of birth, mother's maiden name, social security number in many cases, and so on. One of the things that you see is the information capture, right? And typically this happens at the time of registration. If we don't have the right information for patient registration, we can't bill, we can't really do anything, including provide patient care, because we can't associate whatever patient information with the correct patient. And then again, when we use the term report generation, we've identified the right patient with the right set of information, and we're going forward and generating reports. And again, like we said earlier, the medical record itself, it's the property of the provider. This could be the hospital, this could be the medical office, the hospice organization, whatever it is. And is governed by federal, state, and local laws. The patient has the right to access its contents for review. It's not a type of thing where it's total access anytime you want it under any circumstances. It's subject to federal, state laws. And the provider has the option to maintain as much of the records on-site or off-site. And we see this a lot more of being an issue with paper records. If you're storing them on shelving units, you only have so much office space to stick shelving units. So then typically the medical office will move those records off-site into DeliverX or Iron Mountain or other off-site storage vendors. Even with electronic health records, digital formats, if you've ever had a device that runs out of storage space, is finite, right? And it has a cost. So there's the idea of retention. In other words, how long we'll hold on to this information, which we'll get to in just a minute. The hospital inpatient record documents all the care and treatment that's happened by a hospital admitted to the patient. We'll get into hospital outpatient in just a little bit. And the hospital inpatient record is maintained on paper, or it could be electronic, or it could be hybrid. It's still the hospital inpatient record. It has both administrative, the demographic, financial information, payer information, what have you, and the clinical information that covers the patient at the time that they were admitted to the hospital. Now we get into hospital outpatient. This is hospital ambulatory care. As many of us who've had an x-ray done at a hospital, even though we weren't admitted overnight, these are the types of services. And this could include labs, imaging, x-rays, CT scans, emergency department records, ambulatory surgery, and so on. So the hospital generates hospital outpatient records even when the patient is not formally admitted through admitting to the hospital, because the care is being provided by the hospital on site. Physician office record is the record that's maintained by the medical office. Physicians typically, in most states, don't own the hospitals they admit patients to. Therefore, they have a separate medical office, and all that outpatient care is documented in the physician office record. This includes registration data, administrative information, and clinical information that's generated in the medical office. We also have alternative care clinical services, and these document all these different types of services that are delivered, the standards, the state and federal regulations. Take a look at figure 4.4-2 for more information about this. Now, of course, we don't have records being documented appropriately unless we have responsibilities. And let's start with the provider responsibilities. Joint Commission states that only authorized individuals may make entries in the medical record. The American Health Information Management Association has recommended that anyone documenting in the health record should be credentialed or have the authority and right to document as defined by the organization's policy. And individuals must be trained and competent in fundamental documentation practices of the organization and legal documentation standards. All writers should be trained and follow in their organization's standards and policies for documentation. What does this mean? The Reader's Digest version is that only physicians are authorized to make physician entries. In an electronic health record world, we do this through what we call role-based access, right? So a coder doesn't have the same level of access and can't do the same things in electronic health record that a physician could do or a nurse could do, right? And in a paper world, sure, anybody could pick up a pen and write something, but that is against organization policy. Electronic health records in some ways have solved that by having role-based access, as long as people aren't sharing user IDs, passwords, and other ways to access the electronic health record. The other thing that providers, meaning physicians, nurse practitioners, PAs, or anybody else who's legally authorized to document, is they need to authenticate. And this means such things as signatures. Signatures can be electronic or wet signatures, as lawyers say, that it's signed by hand and scanned, what have you. And certain things have to be countersigned, right? Nurse practitioners, in many cases, along with PAs, have to have their care countersigned by an attending physician. Initials in certain circumstances are also allowed, right? Rubber stamps, signatures, but again, these things have to have policies and procedures about how they're being used. Abbreviations are allowed to be used in the patient record, provided they are agreed upon abbreviations. We just can't have everybody writing their own abbreviations for things. The other thing that was a big controversy that I've actually seen hospitals get cited for in a paper-based world of paper records is legibility. The record has to be legible. And then the last two is it needs to be timely and amended. Timely means that we're not doing discharge summaries on a patient that was discharged 6 months ago. That really doesn't have a whole lot of you, right? And there has to be organizational policies and procedures about that. Then we mean amending, we're talking about making corrections or clarifications. And whether you do this in a paper world where you're drawing a line through the entry, writing your initials and then dating it, or you're doing it electronically where everything shows in its an addendum with the name of the provider, date, and those processes need to be spelled out in your policies and procedures. We covered what a means is basically meaning signed by the author. And there are federal regulations and CMS guidelines about authentications. We also recently, recently meaning in the last few years, have had auto authentications. And what this means is that somebody generates a dictated report, right? And it gets auto signed unless the provider goes in and edits it. And we're seeing this now with speech recognition software. Now with AI, there are actually systems that listen to people dictate, listen to the conversation that a provider is having with a patient, and creates a SOAP note from that. And they're both pros and cons to this type of technology. We talked a little bit about countersigning, and again, what countersigning means is that somebody is having the record and the care reviewed by a provider that's overseeing that mid-level practice, in other words, a physician assistant or a nurse practitioner. And there are both federal and state laws about this, and the Joint Commission, of course, also addresses these counter signatures. In an earlier lecture, I said nothing happens in a hospital unless something's ordered. But since providers are not on site all the time, we have both telephone and voice orders. So a telephone order is basically a verbal order that's taken over the phone by a qualified professional, such as a nurse from a physician. And it looks like something like this. Physician comes in, does surgery on a patient, they're taken to the recovery room, they're taken up to the ward, they develop complications. The nurse who's working the evening shift, after the physician has gone home, calls the physician at home and reports the findings, right? And that physician will speak with the nurse over the phone and order medications, diagnostic tests, what have you. That's an example of a telephone order. A verbal order is similar, except the physician is dictating the order in the presence and directly to the responsible person. Usually this is a nurse. And so we countersign all these. So in a paper-based world, you'd see these nurses writing down these telephone orders. The physician would need to come in, sign, and date these orders. And again, signatures need to be complete. They need to match whatever's on a signature card. In a paper-based world, we used to have signature charts that would have a physician's name, their specialty, their license number, an example of their signature, right? Now with electronic health records, we really don't see that, right? They're accepted in most cases, right? And basically it's considered authenticated because only that particular provider can sign in and write a note, order something directly. We also have seen signature stamps. I worked at a facility where the pathologist basically stamped everything, and there were policies and procedures in place. Every pathologist had to sign a statement saying that they were the only ones who had access to the stamp and they were the only ones using it at that particular facility. Every healthcare facility needs to have a policy about which abbreviations, acronyms, and symbols can be documented in the patient record. This includes having an official abbreviation list, which includes the medical staff approved abbreviations, acronyms, and symbols. And you can see an example of this in figure 4-8 in your book. And that's all I have for you. Come back and we'll finish off patient record content and the rest of chapter 4. We'll see you then.